Today we will see about opioid analgesics. We will start with a case history. A 60-year-old man presents in the emergency department with a broken hip, suffered in an automobile accident, and he complains of severe pain. So, what is the most appropriate immediate treatment for his pain? So, whenever a patient comes to you with a very severe pain, his pain has to be alleviated immediately because the pain makes the patient very anxious, and sometimes the pain may, cause neurogenic shock. Okay, so very severe pain cannot be dealt with a routine NSAID. So for such kind of severe pain, you need opioid analgesics. Opium is obtained from Papaver somniferum, a poppy plant. And Saturner in 1803 he isolated morphine, which is an opiate, and he named morphine after Morpheus, who is the Greek god of dreams. And opiate is a term which includes all the naturally occurring alkaloids like morphine, codeine, thebaine, and papaverine. So all these alkaloids are obtained from these poppy plants. And opioid is the term which includes all the compounds that act on the opioid receptors. So opioid means any drug which acts on the opioid receptors, whereas opiate means the naturally occurring alkaloids. So opioid analgesics you can broadly classified into natural opium alkaloids like morphine and codeine, semi-synthetic opioids, diacetyl morphine otherwise called as heroin, phenol codeine, ethyl morphine, and synthetic opioids, pethidine otherwise called as meperidine, methadone, fentanyl, remifentanil, tramadol, tapentadol. And you have complex action opioids, so they act both as an agonist and antagonist, or sometimes partial agonist at certain kind of opioid receptors, and antagonist or agonist in certain other kind of opioid receptors. So they are called as complex action opioids. So they are classified into those drugs which are agonist and antagonist, like otherwise they are called as kappa analgesics. So they are nalorphine, pentazocine, buterphenol, nalbuphine, and partial mu agonist with plus kappa antagonist, namely buprenorphine. And you have pure opioid antagonist, naloxone, naltrexone, nalmefene. So these are all the classification of opioid drugs. Okay, so you have pure opioid agonist, and you have mixed agonist and antagonist, and you have pure opioid antagonist. So here are the opioid receptor subtypes and the endogenous peptide which act on the particular receptor. So you have endogenous opioid peptides inside your body which are released whenever you suffer from extreme pain. So these endogenous opioids, they physiologically they alleviate your pain. So there are three types of opioid receptors: mu, delta, and kappa receptors, and you have corresponding endogenous opioid peptides which has great affinity towards a particular kind of opioid receptor. For example, you have three types of endogenous opioid peptides, namely endorphins, enkephalins, and dynorphins. Endorphins have greater affinity for mu receptors, and enkephalins have greater affinity for delta receptors, and dynorphins have greater affinity for kappa receptors. And here the mu receptor is the most important receptor which deals with the modulation of supraspinal and spinal pain response. Okay, and kappa receptors are responsible for some psychotomimetic effects which is seen with certain opioid analgesics. Okay, so those opioids which act as an agonist on kappa receptors have some psychotomimetic effects as side effects. Okay, so these are all about the opioid receptor subtypes and their corresponding endogenous opioid peptides. So when you see here, there are certain opioid analgesics which has strong affinity for mu receptors, namely morphine, hydromorphine, oxymorphine, methadone, meperidine or pethidine, fentanyl, sufentanil, alfentanil, remifentanil, levorphenol. Okay, so these drugs have strong affinity towards mu receptors, and you can see codeine has, codeine, hydrocodone, oxycodone. So these have moderate affinity. Pentazocine has moderate affinity, whereas nalbuphine has antagonistic. So here, nalbuphine is mu antagonist. Buprenorphine and butorphanol are partial agonist. Okay, and the drugs pentazocine, nalbuphine, and butorphanol, they have affinity or agonistic actions on kappa receptors, and hence they are called as kappa analgesics. And buprenorphine has both kappa and delta antagonistic action with partial agonistic action on mu receptors. So there are some variations in the affinity towards different kinds of opioid receptors between different drugs, but mostly all the strong agonist mu receptor agonist or the most efficacious opioid analgesics which are used. Okay, and similarly you can see there is difference between the different drugs with respect to oral parenteral ratio. Okay, for example, you can see morphine, hydromorphine and oxymorphine have low oral parental ratio. That means the oral bioavailability is very less, whereas methadone, livorphenol, codeine, so they have high oral parental potency ratio, so they can be given by oral route. Okay, and similarly, so these are the drugs, the first few drugs: morphine, hydromorphine, oxymorphine, methadone, meperidine, fentanyl. So these group of drugs have high maximum efficacy because they are strong agonist on the mu receptors. Okay, and with regard to metabolism, so morphine is conjugated to two different metabolites, morphine 3 glucuronide and morphine 6 glucuronide. So morphine 3 glucuronide, it has some neuroexcitatory properties. So this is the reason sometimes seizures may occur as an adverse effect with morphine administration. And morphine 6 glucuronide is another metabolite, and this is an active metabolite with analgesic action similar to or even more than morphine. Okay, and meperidine or pethidine, so it is converted into a metabolite called normeperidine or norpethidine. Again, this metabolite causes seizures. Okay, so pethidine also has an adverse effect of precipitation of seizures. And codeine, it is actually converted to morphine by CYP2D6 enzyme. So when codeine is metabolized to morphine, it will have analgesic action. So if there is a genetic variation in this enzyme, so the analgesic action of codeine may be less, because if there is less of this enzyme, or if there is any mutation in the expression of this enzyme, so codeine is not adequately converted to morphine, so the analgesic action will be less. And remifentanil, so it is a drug which gets metabolized by plasma esterase. So because of this, it has a very short duration of action. Before going to the molecular mechanism of opioid analgesics, we will just have a quick overview about the pain pathway. So we have two different pain pathways. One is ascending and another one is descending. So this is the ascending pain pathway. It starts from the periphery, the site of the pain stimulus. Okay, so from here, the pain impulse travels through the afferent neuron, primary afferent neuron, and this is the secondary afferent neuron, and gets relayed in the dorsal horn of the spinal cord. Then it crosses and again ascends through the medulla, parabrachial nucleus of medulla, pons, and then it goes to thalamus, where there is a relay, and from there it goes to cortex. So this is the ascending pain pathway. And the descending pain pathway starts from the cortex through the midbrain, okay, medulla, pons, and again dorsal horn of the spinal cord, and then it gets end in the dorsal horn of the spinal cord. So the purpose of the ascending pain pathway is to transmit the pain impulse from the periphery to the cortex. Okay, and the purpose of the descending pain pathway is actually to inhibit the perception of the pain. So it sends inhibitory neurotransmitter, so that the perception of the pain is halted at the level of dorsal horn of the spinal cord. Okay, so it prevents the pain impulse from ascending by sending inhibitory neurotransmitters. But this descending pain pathway is always kept under inhibition. So only when there is pain, okay, only when the ascending pathway is stimulated, this descending pain pathway, the inhibition gets released, and then it starts inhibiting the ascent of the pain stimulus. Okay, so you have to understand there are two pain pathways. The ascending pain pathway is mainly to send the pain impulses to the cortex, whereas the descending pain pathway is mainly to inhibit the perception of the pain. Okay, but this descending pain pathway is always kept under inhibitory control, and the inhibition is released only when needed. So here you can see this first picture is at the site of the synapse between the afferent and the primary and the secondary afferent neuron at the level of periphery. Okay, so at the level of the site of pain. Okay, so here you can see this is the primary afferent neuron and this is the secondary afferent neuron, and you can see the release of neurotransmitters like glutamate and neuropeptide is responsible for the transmission of pain impulses. Okay, so here this is the mu opioid receptors. Okay, the red arrow marks both at the presynaptic and the postsynaptic levels. So whenever this mu opioid receptors are stimulated, it blocks the calcium conductance at the presynaptic level and enhances the potassium conductance. So by both these mechanisms, by both these actions, the release of the neurotransmitter is prevented, and hence the impulse transmission is prevented. So thereby it blocks the pain transmission, and it has action at the descending pathway as well. So as I said, the descending pathways, the main purpose is to inhibit the pain perception. So it is actually an inhibitory pathway. So inhibitory pathway means you have inhibitory neurotransmitters GABA at the synaptic level. So as I said, this inhibitory pathway is always kept under inhibition. So the purpose of this opioid receptor stimulation is to inhibit this inhibition. Okay, so the inhibition of this inhibitory pathway is inhibited. So thereby, so what does it mean? It stimulates the inhibitory pathway. So by stimulating inhibitory pathway, it sends the inhibitory signals and thereby decreases the pain perception, or it blocks the ascending of the pain stimulus to the cortex. Okay, so this is the two different way in which opioid act to decrease the pain perception. Actions of opioids: it causes analgesia. Both the sensory and the emotional or affective component of the pain is reduced. Okay, so unlike NSAIDs, which affect only the sensory component, opioids decrease both the sensory and the affective component of the pain, and it causes euphoria and also sometimes dysphoria. As I said, when the drugs act as an agonist on the kappa receptors, it causes dysphoria, where mu receptor agonistic action causes euphoria, and it causes sedation, respiratory depression, which is the most important um, uh, adverse effect associated with opioid overdosage, and it causes profound respiratory depression and also causes bronchoconstriction because of histamine release. Since morphine is an alkaloid, it releases histamine and causes bronchoconstriction. So both these actions, that is respiratory depression and bronchoconstriction, has to be kept in mind when opioids are used in patients who have less pulmonary reserve. And it causes cough suppression, constipation. So constipation due to opioid is due to decrease in the propulsive movements of the gastrointestinal tract, and increased contraction of the sphincters, decrease in the secretions, and inattention to defecation reflex, which is a central action. So because of all these mechanisms, it causes constipation, and it causes meiosis, and this meiosis is due to stimulation of the Edinger-Westphal nucleus, the third nerve nucleus, and it causes intense pruritus. So these are the actions. And the other actions are, it causes hypotension and bradycardia. So hypotension is mainly due to depression of the vasomotor center, and vasodilatation due to histamine release, and it causes bradycardia, vomiting. It stimulates the CTZ chemoreceptor trigger zone, and it causes vomiting, and it disrupts the sleep architecture. Okay, it disrupts the sleep pattern. It decreases the REM sleep, and temperature regulation is also disrupted. It causes hypothermia, and it contracts the sphincter of OD, and it causes biliary colic. It has antidiuretic action, as well as it reduces the renal blood flow. So because of low in the blood pressure, so because of these two actions, use of opioids in renal compromised patients has to be carefully dealt with, and it lowers the secretion of FSH, LH, ACTH, whereas prolactin and growth hormone secretion, they are raised, and it causes prolongation of the labor, and difficulty in urination is seen, especially in the elderly patients, because it increases both the tone of the bladder and also the sphincter. So because of that, there will be urinary urgency, but at the same time the patient cannot micturate, so there will be urinary retention. Opioids are mainly used in pain management, especially pain due to traumatic, visceral, ischemic, post-operative burns, cancer, and renal colic. So all such kind of pains, they respond better to opioids. It is used in pre-anesthetic medication because of its analgesic, sedative, and anxiolytic properties. It is used in the management of acute pulmonary edema or left ventricular failure because it relieves the anxiety of the labored breathing, and also it shifts the blood from the pulmonary system to the periphery, so it relieves the congestion, and it is used in the management of cough. It is used in diarrhea, so especially non-infectious diarrhea, and it is used in the management of shivering, so especially post-transfusion shivering, and shivering which occurs during post-operative period. So pethidine is especially used for this purpose. There are different routes of administration of opioid analgesics. So apart from oral and parenteral routes like intravenous, intramuscular, and subcutaneous routes, you have other different routes like epidural and subarachnoid route of administration, and it is administered as rectal suppositories, intranasal route, especially buterfenol, intranasal buterfenol, and you have buccal and transmucosal route, especially fentanyl. So fentanyl is it is marketed as fentanyl lollipops, which is used for buccal route, and you have transdermal patches, especially fentanyl and buprenorphine transdermal patches, and you have patient controlled analgesia. So that means patient has control over the the dose of opium. So there will be opium delivery device attached, and the control will be with the patient. So whenever the pain escalates, so the patient pumps in a dose of opioid. So that is patient controlled analgesia. So this is used especially in the chronic management of cancer pains. Adverse effects of opioid analgesics, or actually the extension of the pharmacological effects. So adverse effects seen with acute use of opioids, or respiratory depression. So that is the most important and serious adverse effect, and nausea, vomiting, pruritus, urticaria, constipation, urinary retention, delirium, sedation, and seizures. Adverse effects with chronic use or hypogonadism, immunosuppression, increased feeding, increased growth hormone secretion, and withdrawal effects. So when the opioids are used for a very long period and suddenly stopped, withdrawal effects are seen. Tolerance and dependence, abuse and addiction, hyperalgesia, impairment while driving. So these are some of the adverse effects which are seen when the opioids are used for a prolonged period. So tolerance is one of the important feature which is seen with chronic use of opioid analgesics. So the tolerance can be both because of pharmacokinetic and pharmacodynamic mechanisms. So pharmacokinetic, we all know it is due to increased metabolism of the drug. And pharmacodynamic reason, it's mainly due to receptor recycling. It is concerned with disruption of the receptor recycling. So whenever usually whenever the drug is given, after the drug acts on the receptor gets endocytosed and then again recycled back, so that it gets ready for the next the binding with the ligand. But whenever this recycling is disrupted, or because of receptor uncoupling, there is opioid receptors are G protein coupled receptors, so the receptor has to couple with the G protein for the action to be continued. So when the receptor gets uncoupled from its G protein, again tolerance develops. So tolerance is mainly when more amount of drug is needed to produce the same analgesic effect, then we call it as a tolerance. And to counteract the tolerance or to overcome the tolerance, we use NMDA receptor antagonist. They are found to recouple the receptors to their target ion channels. So NMDA receptor antagonists are used to overcome the tolerance. And also opioid rotation can be done. See, suppose if you are using morphine for a particular period of time, then you can when tolerance develops, then you can change or switch over to another opioid, like buprenorphine or some other opioid. So you can rotate the opioid in such a fashion that tolerance is avoided. So there are certain actions for which tolerance develops, and there are certain actions for which tolerance doesn't develop. So high tolerance is seen for analgesic action, euphoria, dysphoria, sedation, respiratory depression, antidiuresis, nausea and vomiting, cough suppression. So these actions are more prone for development of tolerance, whereas no tolerance is seen for meiosis, constipation, and convulsions actions. So even though the patient takes opioid for very prolonged time, these actions, meiosis, constipation, and convulsion, doesn't show any tolerance. So this has a clinical significance, because whenever the patient who are dependent on opioids or who are taking opioid for a very long duration of time comes with acute morphine poisoning or acute opioid poisoning, then certain actions may not be seen because of development of tolerance, but you can see very constricted pupil, okay, and constipation and seizures. So these actions will be seen, okay, because of no tolerance developing for these actions. So now we'll see about acute morphine poisoning. So this can be due to accidental, suicidal, or it can be seen with drug abusers. So we all know opioids are prone to cause dependence, abuse, and addiction. So the presenting features will be stupor or coma, flaccidity, shallow and occasional breathing, cyanosis, pinpoint pupils, falling BP, and shock. So management of this acute morphine poisoning includes respiratory support. If the patient is not breathing, then proper respiratory support with assisted ventilation should be given, and maintenance of BP should be done with IV fluids and vasoconstrictors if needed, and gastric lavage is done with potassium permanganate in order to remove the any leftover morphine in the stomach, even if morphine is given through parenteral route. So this drug will be secreted in the gastric lumen, and since it is a basic drug, it gets ionized and trapped inside the gastric lumen. So even if the morphine is given through parenteral route, a gastric lavage can be done in order to remove the secreted morphine in the stomach. And the specific antidote for morphine poisoning will be naloxone, which is a pure opioid antagonist. It's a very short acting drug. So zero point 0.1 to zero point 0.4 milligrams of naloxone is given intravenously, and it is repeated every 2 to 3 minutes till the respiration picks up. Okay, so if the patient is in coma, till he starts breathing spontaneously, you have to keep on repeating naloxone. And also maintenance dose 0.4 to zero point 0.8 milligrams should be given IV, and it should be repeated as and when needed, because it is short acting. It has to be given very frequently. And the next important thing is opioid withdrawal. So, chronic opioid use produces physical dependence. So, when it is stopped abruptly, it produces withdrawal symptoms. So, the withdrawal signs and symptoms will be rhinorrhea, lacrimation, yawning, chills, piloerection, hyperventilation, hypothermia, mydriasis, muscular aches, vomiting, diarrhea, anxiety, and hostility. So the management of withdrawal symptoms will be symptomatic, and you can use clonidine, which is an alpha 2 agonist. Since the withdrawal symptoms are mainly due to sympathetic overactivity, so this clonidine can be used. And substitution therapy with methadone or buprenorphine can be given, because methadone and buprenorphine are longer acting opioid analgesics. So they don't cause these acute withdrawal symptoms very frequently like your strong agonist like morphine. Okay, so if the patient is taking a strong agonist like morphine, so it can be replaced or substituted with longer acting drug like methadone and buprenorphine, and then it can be slowly withdrawn. So this is the management of opioid withdrawal. And another problem with opioid use is opioid dependence. So whenever the patient is dependent on opioid, so you cannot withdraw the drug suddenly because it produces withdrawal symptoms. So you can substitute with methadone and slowly withdraw. So once the patient achieved de-addiction, or once the patient stops taking the opioid, then so you can prevent further craving by giving naltrexone, which is a longer acting opioid antagonist. So this reduces craving. Okay, so opioid dependence should be managed very cautiously. So you should not precipitate any withdrawal symptoms or signs. So you have to gradually substitute a strong opioid agonist with a longer acting drug like methadone. Then you have to slowly withdraw. And once the patient is completely de-addicted, then the further addiction is prevented or further craving is prevented by using opioid antagonists like longer acting opioid antagonists like naltrexone. The main contraindications and cautions with opioid use are you should not give a pure agonist and partial agonist together. So when partial agonist is given along with pure agonist, it acts like an antagonist. So the efficacy of the pure agonist would be reduced. So both this should not be given together. And opioid use should be very restricted in case of head injuries, because in head injury there will be raised intracranial pressure already, and when you give opioids, it causes respiratory depression and cause carbon dioxide retention. Again, this causes cerebral vasodilatation, which is again going to increase the intracranial pressure further. So it if no opioid use if opioid is given for head injury patient, there may be a risk of herniation. So you have to avoid opioids. And pregnancy should use very cautiously, because opioid analgesics cross placenta, especially morphine, and the fetus will be dependent on opioids. So when the child is born, sometimes the baby will show withdrawal signs and symptoms. So it has to be used very cautiously. And you have to use opioids very carefully in patients with impaired pulmonary function because of the respiratory depression, and again with impaired hepatic or renal function, and endocrine diseases, and undiagnosed acute abdominal pain. Because if you give acute abdominal pain, if it is due to biliary colic, and if you give morphine for pain relief, it's going to aggravate the condition. And you have to be very cautious when you use opioid analgesics in elderly males, because it's going to cause urinary retention. So these are the main important contraindications and cautions with opioid. Opioid analgesics are especially used in the management of severe pain in hospitalized patients. So they are prone to cause many drug interactions, because the patient will also be taking sedatives and hypnotics. So there will be increased risk of respiratory depression when both these drugs are taken together. And also it interacts with antipsychotic agents, because the cardiovascular effects will be accentuated because of the anti-muscarinic and alpha blocking actions of these antipsychotic agents. And similarly, opioid analgesics, when taken along with monoamine oxidase inhibitors, there will be increased risk of hyperpyrexic coma and hypertension. And we will see now some of the individual drugs. Okay, so we'll see now the strong agonist of mu receptors. So you have morphine, methadone, and fentanyl. So these three drugs are strong mu receptor agonists with variable affinity for delta and kappa receptors. Hydromorphone and oxymorphone, so they are like morphine in efficacy and higher potency. And meperidine or pethidine, it is a very strong agonist at mu receptor with anti-muscarinic effects as well. So because of this anti-muscarinic effects, it causes tachycardia, and this pethidine is especially it is not preferred analgesic in myocardial infarction because it causes tachycardia and increase the workload of the heart. And oxycodone, it causes dose dependent analgesia. Sufentanil, alfentanil, and remifentanil, these are like fentanyl but shorter duration of action. Codeine and hydrocodone, these are again mu receptor agonist but less efficacious than morphine. They are used in mild to moderate pain and in the suppression of cough, especially codeine is used in cough suppression. Now we will see about mixed opioid agonist antagonist, or otherwise called as kappa analgesics. So these are the group of drugs which act as partial agonist or antagonist at mu receptors and agonist at the kappa receptors. So you have nalbuphine, pentazocine, and buprenorphine. So these three drugs have kappa agonistic action and hence they are also called as kappa analgesics. So the main feature of these group of drugs are they produce dysphoria and psychotomimetic effects as their adverse effects when they are used for analgesia. And you have buprenorphine, which is also a mixed opioid agonist and antagonist, but it has kappa antagonistic action. So it has partial mu agonistic action and kappa antagonistic action. It is used in the management of moderate pain, and also like methadone, it is used in the management of morphine dependence. That is, it is longer acting and hence it can be used as a substitution therapy in the place of morphine in case of morphine dependence. And it has a very longer duration of action because it dissociates from the receptor very slowly, and hence it has a very longer duration of action. And because of this reason, naloxone, which is an pure opioid antagonist, it only partially reverses the action of buprenorphine. So naloxone reverses almost all the opioid analgesics completely except buprenorphine, which dissociates very slowly from the receptor, and hence the reversal also is very partial. An opioid antagonist, you have three main opioid antagonists: naloxone, naltrexone, nalmefene. Naloxone is a shorter acting opioid antagonist, so it is used in the management of opioid overdosage, acute morphine poisoning. Naltrexone is an oral, longer acting drug. It is used in the management of dependence because of its longer action, and it is used in the patients who are detoxified from opioid addiction, and to maintain the abstinence, naltrexone is used. So similarly, it is used in the management of alcohol and nicotine dependence as well, and it is also used in the management of obesity in weight loss programs. Along with buprenorphine, it is used in weight loss. And nalmefene, it is a longer acting drug given intravenously. And you have two opioid antagonists which has more peripheral action, so they act on peripheral mu receptors with less central action: methane naltrexone bromide and albumin. These two drugs are peripheral mu receptor antagonist. So they are used in the management of constipation and post-operative EDS following any bowel resection surgery. So because their action is restricted peripherally, it doesn't have any central side effects, and hence they are used for such conditions. And then you have atypical opioids. So these two drugs, tramadol and tapentadol, these two drugs, they have a moderate mu agonistic action, and also they have additional norepinephrine or serotonin reuptake inhibiting action as well. So they are called as atypical opioids. So tapentadol, it is used in the management of moderate pain, and the main toxicity is since it inhibits the norepinephrine and serotonin reuptake, it can cause serotonin syndrome when it is used along with SSRIs. So same with the tramadol as well. So it is these drugs are used as an adjuvant to opioids in chronic pain syndromes. To summarize, morphine is the prototype of opioid analgesics. So, analgesia is the most important action, and it is the most important use of opioid group of drugs. It affects both sensory and affective components of pain, especially deep visceral pain responds much better to opioid analgesics. There are three types of opioid receptors: mu, kappa, and delta. Respiratory depression is the most common and serious adverse effect which should be carefully monitored while using opioid analgesics, and they are more prone to cause tolerance, dependence, abuse, and addiction. Naloxone is a specific antidote for the management of opioid overdose and poisoning. Methadone is a long-acting mu receptor agonist which is used as substitution therapy in the case of opioid dependence. So, opioid use should always be balanced. So, you should be cautious as it causes respiratory depression. But again, the same should not be a limiting factor in using opioid for the management of severe and chronic pain like cancer pain, etc. Thank you.